Good morning, everyone. We're going to go ahead and get started. My name is Meridale Baggett. I'm one of the core educative faculty in the Department of Medicine, and I'm also one of the associate editors of the New England Journal of Medicine Case Records of the Massachusetts General Hospital. And I'm happy to welcome you guys all to this CPC today. Hopefully, in addition to members of the Department of Neurology joining us both in person and via Zoom today, we're excited to also have hopefully many members of the Department of Emergency Medicine as well. Our primary discussant today is Dr. Jonathan Edlow. So Dr. Edlow is a professor of both medicine and emergency medicine at Harvard Medical School and is a national and internationally renowned expert in neurological emergencies. And you guys will see very quickly as we present this case why he was a perfect fit when we asked him to discuss this case. Dr. Edlow is discussing the case in the traditional unknown format, which means that the only thing he knows about this patient is a approximately 2-page summary that I sent to him about 6 weeks ago so that he could prepare his discussion. And we do this partly because it's fun and partly because it allows us to really give him the opportunity to walk us through how he would think through this patient in real time without the benefit of already knowing the diagnosis. So we're very excited to learn from his clinical reasoning and his approach to the patient today. Dr. Edlow will be joined by Dr. Singhal and Dr. Romero to round out our conference. But first, it's my distinct pleasure to welcome up one of my former interns when she did her prelim year with us here at Mass General, Dr. DiCarlo, to present the case history today. Dr. DiCarlo.
Thank you for the introduction. I'll start with the history. So this is a 64-year-old woman who's presenting with a chief complaint of sudden onset, worst headache of her life. The patient was at a condo association meeting on the night of presentation when she stood up to speak and had sudden onset, worst headache of life. She described the headache as bilateral, frontal, and pulsatile. The pain reached maximum intensity within seconds and was rated as a 10 out of 10. The pain not speak without access. She sat down, but the pain did not get any better. She repeated to her husband, "Something's really wrong." After 30 minutes of symptoms, they called EMS and she was brought to the emergency department. On arrival, she reported ongoing headache and associated nausea. In terms of her past medical history, she has a history of hypertension. She's on hydrochlorothiazide for this. She has menopause and she's on conjugated estrogen tablets every 3 days. She also has cervical stenosis. She has no known drug allergies. In terms of her social history, she's a lifelong non-smoker. She occasionally drinks alcohol, but reports no other drug use. She's working as a secretary and she is married, living with her husband. Family history is notable for diabetes. On physical exam, she's afebrile. Her blood pressure is 155 over 77. Her heart rate is 77 beats per minute. She's breathing 16 times per minute. And her oxygen saturation is 96% on Romero. She was noticed to be alert and oriented to person, place, and time. Her neck was supple without signs of meningitis. Her speech was fluid, and she had intact naming, repetition, and comprehension. Her cranial nerve exam was normal. Her visual fields were full to confrontation. Her retina appeared normal, as did the optic disc. Her motor strength was intact throughout. Sensation was normal. Reflexes were normal, and she had normal cerebellar function tests. Initial labs included blood glucose, which was normal, BMP, CBC, and coags, all of which were normal. A head CT without contrast was performed 2 hours after the onset of the headache. This demonstrated subarachnoid hemorrhage, which layered along the left high posterior and paramedian bryosis side. Additional labs were drawn at that time. This was about 4 hours after the onset of headache. They were notable for ESR and CRP within normal limits and an elevated troponin T of 0.36 nanograms per milliliter. An EKG was performed and demonstrated normal sinus rhythm with first-degree AV block. Here's her EKG. She was given IV morphine for the pain and IV promethazine for the nausea. Both the nausea and the headache improved with these medications. Additional testing was performed. And invite Dr. Romero now.
Good morning. Here we have additional images. We have a non-contrast CT ahead at admission, and we can appreciate this high density, which follows the sulci of the upper parietal lobule, showing likely a subarachnoid hemorrhage. This is a reconstruction in coronal, just demonstrating how this high density follows the gyriform pattern, likely confirming its subarachnoid location. Or with differential.
All right, thank you very much. Let me know if I drift the microphone and you can't hear me. There's no way you can't hear me. So just to summarize, we have a 64-year-old patient who's pretty healthy. She has a thunderclap headache that began when she was about to speak to a group at her condo association. She takes estrogens, but has no family history of venous thromboembolism. She has a mild systolic hypertension, but otherwise a very normal exam. Her inflammatory biomarkers, the SED rate, the CRP are normal. Her EKG actually, I think, shows diffuse submillimeter ST segment changes, nothing actionable, but by definition, the TP segment is the isoelectric baseline. So she does have some EKG changes that are minimal, but a very elevated troponin. And of course, the convexal subarachnoid hemorrhage that we just saw. So the correct diagnosis has to explain three key elements: the headache, the troponin, and the convexal subarachnoid hemorrhage. And I'll discuss and go through each one of those sequentially. Headache is a very common cause, chief complaint in the emergency department. And about 15% of headaches in the ED are thunderclap headaches. The famous case report that came out in 1986 in Lancet by Day and Raskin. And I can actually remember discussing this case report with one of my colleagues, Gary Setnick at Mount Auburn Hospital, because the conclusion they came from this case report was that we need to do or think about doing an angiogram. And back in 1986, an angiogram meant a groin puncture and a catheter angiogram. There was no CTA back then. So their patient was a 42-year-old woman. She had 3 thunderclap headaches. And again, they coined that term. She described it like a hammer hitting her head. She was neurologically intact. Brain CT and lumbar puncture were normal, and she was discharged. She came back 5 days later, having had 2 more thunderclap headaches. And this time she had angiography that revealed a 1 centimeter carotid artery aneurysm and diffuse vasospasm. They thought the aneurysm was etiologic, so it was surgically clipped. She did well, went home, and had a follow-up angiogram a month later. So the International Headache Society defines a thunderclap headache as severe intensity, abrupt onset that peaks within a minute, lasts at least 5 minutes, and not better explained by some other diagnosis. And I have a problem with that second criterion. Don't use that second criterion, peaking within 1 minute. Patients are often unable to be that precise about such small increments of time. One, if you think about BPPD, for example, the pathophysiology, the dizziness should last 20 seconds, 30 seconds, maybe up to a minute. But it's very common for those patients to say, I've been dizzy for, an hour or 30 minutes or even days in some cases. Furthermore, there's a couple studies looking at patients with thunderclap headache. It was an older Dutch study that looked at 102 patients with thunderclap headache, and 42 of them had a subarachnoid hemorrhage. And 20% of the subarachnoid hemorrhage patients had peak between 1 minute and 5 minutes. A much larger study done by the Ottawa group in Canada looked at over 2,000 patients. These were neurologically intact emergency department patients. And they, by design, study included patients who had a headache peaking within 1 hour. And of the 2,000 and so patients, 132 had a subarachnoid hemorrhage. Of those 132 patients, about 20% of them peaked beyond 1 minute, and 5% of them peaked at about 1 hour. So I don't think that we can really or should really be using that 1 minute. And in practice, I don't. If someone, I ask the patient, I always ask the patient about the onset. I ask them what they were doing at the onset. And if they can remember exactly what they're doing, but they can't say it's within a minute or within 5 minutes, I work that up as a thunderclap headache. Because in practice, if you were to slavishly and rigidly follow the IHS criteria, you would miss a lot of patients with serious diagnoses. So the first diagnosis in my mind, and in any, I guess all of our minds as neurologists or emergency physicians, is an aneurysmal subarachnoid hemorrhage. And any ED evaluation needs to exclude that. But once it's excluded, there's a lot of other potential causes that we'll talk about. This is an algorithm that I use. Only allotted 25 minutes, so I'm not going to go through the algorithm. I'm rather fond of it with all its pretty colors and things. But in this particular patient, we would hop off the algorithm at the first box because this patient does have a positive CT scan of a convexal subarachnoid hemorrhage. And we'll talk more about that later. So the differential diagnosis of thunderclap headache or primary headache disorders, primary thunderclap headache, often called bathing headache, orgasmic headache, exertional headache. Many of these patients probably have another diagnosis that we'll discuss later, and then migraine. And then there's a bunch of different causes of secondary headache causes that we'll discuss in more detail, some of which are relatively common, some of which are very uncommon, and many of which are extremely rare. So as an emergency physician, I probably think about the world a little bit differently than most neurologists. I want to diagnose time-sensitive, cannot miss conditions. And by that, I mean conditions for which there's an effective treatment, without which patients are going to have a bad day and a worse outcome. I need to stabilize patients that are physiologically unstable, and I need to make the correct disposition. Home, hospital, if it's hospital, which service, is it ICU, is it floor? And for me, not being wrong, sensitivity is much more important than specificity, which is being right. And the best example I can give you is if I have a hypotensive trauma patient and I put the probe on their belly and I have intraperitoneal fluid, I don't need to know whether it's a ruptured spleen or a lacerated liver or a torn mesenteric vein. I need to take the next steps of getting IV access and transfusing blood and getting that patient to the operating room. Surgeon to make that definitive specific diagnosis and fix the problem. So let's look at 100 neurologically intact emergency department patients with thunderclap. About 85% of those patients are not going to have any brain pathology when workup, and about 15% will have serious secondary causes. Now, this patient had an abnormal CT, so by definition, she falls off of that primary thunderclap headache, or primary headache disorder, I should say. So now we're dealing with those 15 patients with a secondary cause. If we look at those 15 patients, about 6 out of 15 or 6 out of 100 will have a subarachnoid hemorrhage. And this, again, is work done by the group in Ottawa in 2 sequential studies of emergency department patients with headaches that peaked within 1 hour, again, by design within 1 hour. 6% of those 4,000 or so patients had a subarachnoid hemorrhage. So that's pretty good data. It's probably the best data we have about this. So step 1 is to rule out a subarachnoid hemorrhage. The traditional paradigm is CT followed by lumbar puncture, but increasingly emergency physicians are doing CT, CTA, or even CT alone. I'm not fond of either of those protocols for a variety of reasons that I don't have time to get into here. But CT is a great test if it's done within 6 hours of onset of the headache. It's almost 100% sensitive, but the sensitivity rapidly degrades with time. And the reason it degrades with time is that there's a very brisk flow of cerebrospinal fluid. It's manufactured in the cortical plexuses. It goes all around the cerebellum, the spinal cord, the hemispheres, and then it gets reabsorbed in the arachnoid granulations that live in the sagittal sinus principally. At any one moment in time, we have about 150 cc's of spinal fluid in our system, but we make about 450 cc's every 24-hour period, which means we make about 20 to 25 cc's every hour. And it's important because it helps to explain the degradation of CT sensitivity. It explains why sagittal sinus thrombosis, for example, will cause increased intracranial pressure. And one can also leverage this physiological fact to help tease out a traumatic LP from a true subarachnoid. And about 50% of LPs, even done by experienced operators, will be traumatic. And what I'll often do when I have blood is I'll waste some fluid, 5, even 10 cc's. If you remember the flow, about 20 to 25 cc's being made every hour. By the time that fluid gets processed in the lab, the patient will remanufacture that fluid. So I'll try to waste fluid till I get crystal clear CSF. And a lot of times, even with a traumatic tap, you can bring it down to 0 red cells or 10 or 15 or 20. something like that, you can probably get enough information to safely exclude a true hemorrhage. All right, so back to our patient. She's treated with some IV morphine and promethazine. The nausea resolves, the headache improves, but doesn't go away completely. What conclusions can we draw from that? A lot of patients who come to the emergency department with pain are very anxious. A lot of them have some hypertension, and we can tease out hypertension due to pain and anxiety versus hypertension due to the body auto-regulating and trying to increase cerebral perfusion pressure in an area either injured or ischemic brain. Because if the hypertension resolves with treatment of the pain, then that helps you sort that out. And obviously, it's the humane thing to treat the pain. But it's important to recognize that improvement, even complete improvement with pain, and even with the triptan, for example, does not mean that the cause is a benign cause of headache. There are multiple case series and case reports of patients with all kinds of headaches, from carbon monoxide poisoning, from brain tumor, carotid dissection, who have gotten better with all sorts of different analgesics. So treat the pain, but don't use the successful relief of pain as an indication of a benign etiology. So let's get back to the differential diagnosis. I'm going to work backwards with the thunderclap headaches and talk about the rare causes. Each of these causes is extremely unlikely, just statistically. These are sort of case report level evidence. Meningitis and encephalitis, she has no fever, there's no altered mental status, no meningismus, the biomarkers are normal. I'm going to take that off the list. A symptomatic unruptured aneurysm, there's no third nerve palsy, and the blood in the brain would not be explained by an unruptured aneurysm. You take that off the list. There's no hydrocephalus in terms of colloid cyst of the third ventricle. A retroclival hematoma, which I've never seen, should be seen on the CT, and it wasn't. Giant cell arteritis was a good thought that people were obviously thinking about because of the patient's age, but to have both biomarkers normal and presumed normal temporal arteries, I'm going to take that off the list. Transient global amnesia, she didn't have that. I'm going to take that off the list. When I get to these two bottom ones, it brings up that troublesome troponin. So it brings up this second element of the case, and I'm a little nervous about taking those off the differential diagnosis too early. Painless aortic dissections, meaning absence of chest or back pain, do occur. They're not super common, but they're not that rare either. But they're not completely asymptomatic. So without some evidence, clinical or laboratory, of either brain or gut or kidney or limb ischemia, it's extraordinarily unlikely, but there is at least one case report that describes such a patient. In terms of MI, again, there's no cardiopulmonary symptoms. The EKG does show that borderline first-degree block and some very minor sub-millimeter diffuse ST segment depressions, but nothing actionable. But again, that troponin is 10 times the upper limit of normal. So once I get that back, we're going to put the patient on telemetry. We're going to consult cardiology, cycle the cardiogram of the troponin, and avoid the temptation to get any antithrombotics due to the blood in the head. So how do we explain the troponin then? I think the likeliest explanation is Takotsubo or neurogenic stress cardiomyopathy. It's the best fit. Pulmonary embolism crossed my mind briefly in terms of the troponin. But when pulmonary embolism causes this problem, it's almost always in a hypotensive patient, not a hypertensive patient. And it's almost always with some right heart strain, which was not present on the EKG. Takotsubo, also, she fits that epidemiologically in a large international registry of about 1,700 patients. The average age was 67, and 90% of the patients were female. And the LV has wall motion abnormalities. The word Takotsubo comes from the Japanese word for octopus trap, and the LV assumes the shape of that octopus trap. She should get an echocardiogram, which I predict will show LV wall motion abnormalities and probably apical ballooning typical of Takotsubo. So Takotsubo is my explanation for the troponin. Let's keep moving with the differential diagnosis of thunderclap headache. A venous sinus thrombosis, about 15% of patients with a sinus thrombosis will present with a thunderclap headache. She is on estrogens. I'm not sure how I can quantify that as a risk factor, but I think of it as a risk factor. I'm going to keep that on the list for right now. In terms of arterial dissection, there's a series of almost 1,000 arterial dissections, about 2/3 carotid, 1/3 vertebral, And in that series, fewer than 4% of the carotid dissection patients and fewer than 10% of the vertebral artery dissections presented with a thunderclap headache. It's lower than I think I would have guessed without that study. I'm going to leave that on the list for right now. Posterior reversible encephalopathy syndrome, which was described first at Beth Israel. The headache is very rarely a thunderclap headache. Patients usually have seizures which precede the headache. Visual symptoms or signs are usually present, altered mental status. I think that's a pretty unlikely diagnosis. Eclampsia, preeclampsia, she's not pregnant or postpartum. A pituitary apoplexy or a bleed into an adenoma. She has no known adenoma, although granted, apoplexy sometimes is the presenting syndrome or symptom, but she has no ocular motor palsies. She has no field cut, so I'm going to take that off the list. Sphenoiditis should be seen on the CT, and it's not. Spontaneous intracranial hypotension. The headache characteristics are wrong for that, and the cerebellar tonsils had a normal lie, which would also argue against that. And in terms of posterior circulation stroke, there's no measurable neurological deficit, so I'm going to take that off the list. So the two most common causes of thunderclap headache are subarachnoid hemorrhage and reversible cerebral vasoconstriction syndrome, and that's sort of what I have on my list for the headache. So subarachnoid hemorrhage is certainly the thing that worries emergency physicians the most, and it's the most time-dependent diagnosis because there's a lot of different management and treatment steps that have to follow very quickly. Reversible cerebral vasoconstriction syndrome, I'll show you some data in a minute, but probably accounts for as many and possibly a little bit more frequently as a cause of thunderclap headache in an emergency department population than subarachnoid. It's much less time sensitive. It's being increasingly recognized, largely by Dr. Singhal's work over the last couple of decades. But after a single thunderclap headache and prior to any vascular imaging, it's kind of hard, well, it's impossible to definitively make that diagnosis. Of course, every second or third or fourth thunderclap headache has to be preceded by a first one. Talking at Mass General from the Department of Neurology about reversible cerebral vasoconstriction syndrome with this guy in the audience is a little bit intimidating, and it's kind of like bringing coals to Newcastle, but I will do that nonetheless. So does RCVS really cause 8% of ED patients with thunderclap headache? There's two studies that inform this. One is a relatively small Dutch study of just 34 patients. And these are patients in whom an aneurysmal subarachnoid was already excluded. And they found that 8.8% had RCVS. And in a much larger Korean study, they found almost the same number. And anecdotally, I can tell you, I had never heard of this diagnosis until about 15 years ago. And now that I do know about the diagnosis, I seem to be seeing it more frequently. Hippocrates is alleged to have said, life is short, heart is long, experience misleading, and judgment difficult. I'm paraphrasing a bit, but if you think about, you can't diagnose something that you don't know. If you had a patient who lived on Cape Cod and was an avid gardener that came in with a peripheral seventh nerve palsy, you're instantly, and they presented in July, you're going to think about Lyme disease before you think about anything else. But if you saw that patient in 1975 or 1976 or 77, you wouldn't think about it because it was barely a thing back then. So learning about reversible cerebral vasoconstriction syndrome is important. There's clinical factors, but these don't help me very much because this applies to anybody with a single thunderclap headache. There's laboratory and imaging features. We don't need spinal fluid here because you've got subarachnoid blood. I don't have an angiogram yet. And the aneurysmal subarachnoid hemorrhage business we'll get to in a second. Convexal location would be an extraordinarily unusual location for blood in an aneurysmal subarachnoid hemorrhage, but there is case report level evidence that shows it can occur. And of course, evolution over time, we're now at 4 hours into the case, not 4 weeks or 12 weeks. So these diagnostic criteria really are looking through the rearview mirror and don't help me in the emergency department. There's 2 diagnostic scores. Again, neither of these really help me that much. The first one was developed here by Aneesh and colleagues. We don't know about carotid artery involvement at this point. We're going to talk in a moment about vasoconstrictive trigger, but there's nothing super obvious. And then there's another one that was developed with fairly similar criteria in Korea. And they talk about a blood pressure surge, which we really don't have evidence for, but could have occurred before she hit the emergency department. So neither of these really helps me very much. So in this case, the convexal subarachnoid hemorrhage is sort of a diagnostic gift, and I'm very appreciative to receive it because it helps to narrow our differential diagnosis. Traumatic subarachnoid hemorrhages are the most common cause of subarachnoid hemorrhage by far, but she had no trauma. This is just an obvious aneurysmal subarachnoid hemorrhage where you can see blood in the basal cisterns, the interhemispheric fissure, the sylvian fissure, and those lateral, the temporal lateral ventricles are beginning to look dilated to me. About 8%, 10% of subarachnoid hemorrhages, spontaneous, non-traumatic, are perimesencephalic hemorrhages, usually venous bleeding. The blood is usually localized anterior to the brainstem. And then this is what we're dealing with that we just saw an example of earlier, convexal subarachnoid hemorrhage. So the differential diagnosis of this, the two most common causes in young patients is RCBS, and in older patients, amyloid angiopathy. So this patient has the single thunderclap headache. You know, in someone that's unaccustomed to speaking publicly, and I can remember the first time I gave about 35 years ago, I was literally trembling, I was petrified. So this patient getting up to speak at her condo association, it's plausible to me that that was enough of anxiety provoking and was associated with a sympathetic surge that it could be a trigger. And in addition, Takotsubo has been described in association with vasoconstriction. So we'll leave that on the list. Amyloid angiopathy usually presents with TIA-like events. It doesn't present with headache. Patients are usually older. I'm going to take that off the list. Venous sinus thrombosis is now on both sides, so we're going to keep that. Ruptured mycotic aneurysm without fever, murmur, normal biomarkers. I'm going to take that off. There's a bunch of other vascular problems that are potential causes of a convexal subarachnoid hemorrhage. I really can't take them off without imaging. I'm going to leave it on for now. And again, PRESS, for all the reasons I said before, I don't think is the primary diagnosis. Now, there is a link between RCBS and PRESS, and it's conceivable to me she has PRESS, but if she does, I think it's a secondary phenomenon. And large vessel atherosclerosis is also associated with convexal subarachnoid hemorrhage, but it doesn't have a headache, and the mechanism is unclear, but I'm going to take that off the list. So if we look at the confluence of these two lists, reversible cerebral vasoconstriction is, I think, by far the most likely. You know, she's a little old for CVS, and she fits with a lot of the things for venous sinus thrombosis. So that's certainly something that I continue to be concerned about. Dissection is much lower down. And I would just remind myself and everybody that we still haven't definitively excluded a cerebral aneurysm. So I think that this is RCBS with Takotsubo. The test, I think, should be a CTA of the head and neck that includes the aortic arch and the venous sinuses. All of my potential target diagnoses will be diagnosed with an angiogram, except for PRESS. At most places on the planet, that's going to be a CTA. Maybe here it's an MRA, but most places it's going to be a CTA. So the next management steps are to treat her pain, treat her anxiety, talk to the patient and her husband, consult neuro and cardiology. She needs to be on telemetry. We need to cycle the EKG and troponins. She needs an echo. I would allow the blood pressure to auto-regulate for right now until I have a reason not to. And I would speak to the radiologist. And this last point is, you know, we live in a world where we can press a button or two on Epic and say headache, pull out bleed, or pull out mass, or, you know, one or two words. It doesn't give our radiology colleagues as much information that would help them make a specific diagnosis. And therefore, it's not great for patient care. So I want to speak to the radiologist and say, hey, look, I want to cut the aortic arch to try to maximize the likelihood of her visualizing the venous sinuses, and most CTAs will. We still need to eliminate an aneurysm and to look for the smaller vessels. If the CTA is diagnostic, you know, we're done, great. If it does not show a specific diagnosis, it's still most likely reversible cerebral vasoconstriction, I think, because in the first week, the smaller, more distal vessels are involved, harder to see on the CTA, and then it works its way centripetally. I would try to review the films with the radiologist, verify these other things, consider an MRI for PRESS, and then admit the patient to a neurotelemetry bed with cardiology following. Thank you very much.
Thank you so much, Dr. Edlow, for walking us through how you would approach that patient. I would like to invite Dr. Romero to come back up and walk us through the additional radiology.
Thank you. So here we have, trying to answer your questions regarding the CTA. Here we have a coronal and a sagittal view of a CT angiogram, and it is very clear this appearance of the anterior cerebral artery, where we see the segmental narrowing and even in parts lack of contrast filling of this anterior cerebral artery branch. The coronal views show the MCAs here in the proximal segment. They appear quite normal. However, I'll show you a few other images of this. Regarding your question on sinus thrombosis, this is the view of the CTV performed that same day, and you can see the entirety of the superior sagittal sinus, great sinus, and of the transverse sinus, with complete filling of these sinuses, as well of the major cortical veins. We did not have a imaging going through the aortic arch to discard that. We only performed CTAs of the head. Thank you.
Thank you. Aneesh Singhal, I was not the treating physician, but I'll tell you what the management. After the CTA, additional tests were conducted, including cardiac ultrasounds, which showed normal left ventricular cavity size and systolic function, but there were segmental left ventricular wall motion abnormalities present in the middle of the anterior septal and inferior septal walls. As you'll hear later, this patient was readmitted and the findings were reproduced on the second cardiac ultrasound on the second hospital stay. The CSF examination showed 3 nucleated cells, 9,050 red cells. That was on tube 4 and also a little higher in tube 1. Glucose count was normal at 57 and the proteins were elevated at 76, which were attributed to the red cells. The clinical team's diagnosis was the reversible cerebral vasoconstriction syndrome on basis of the segmental arterial narrowing on CTA, the female gender, thunderclap headache, convexity, or non-aneurysmal subarachnoid hemorrhage, and they attributed the onset to triggers, including anxiety when she was speaking and perhaps the estrogen exposure. The cardiac findings were attributed to Takotsubo cardiomyopathy, either related to stress from the severe extreme pain or possibly coronary vasoconstriction concomitant to the intracranial vasoconstriction. I'll now wear a new hat as a management discussion, and I'll provide a brief overview of RCVS. This is a group of conditions which are similar. The clinical imaging features are identical, which are characterized by reversible segmental constriction and dilatation of the intracranial arteries. There are several triggers, associated conditions. Multiple cohort studies have confirmed that there's a preponderance in women. The mean age is approximately 42 years, with an age range of about 9 to 70 years. Children can be affected. More than 90% have recurrent thunderclap headaches, which may or may not meet the definition, the IHS definition. Brain MRI is usually, and CAT scans are usually normal in the first pass, but a serial imaging may reveal developing brain hemorrhages, infarcts, or PRES. RCVS is invariably a self-limited condition with a benign outcome. Headache usually subsides within a few days to weeks, and the angiographic reverse follows. Clinical outcome is excellent, with the discharge modified Rankin Scale score of 0 to 2 in 95% of patients who were admitted. It's probably even better if you account for patients who were discharged from the emergency department. It turns out that there's a long history of RCVS. This is not a new syndrome, but has been reported in the world literature since at least the 1960s by various medical specialties using different terms. At this hospital, Dr. C. Miller Fisher described it as a case series of 16 patients, and in the field of stroke, it became known as Coles syndrome or Coles-Fleming syndrome. When I started investigating based upon patients I had admitted at this hospital, we quickly realized that the clinical imaging features of these entities were the same, and we proposed that this was indeed a benign syndrome, distinguished this from inflammatory angiitis, and proposed the term reversible cerebral vasoconstriction syndrome to enable prompt recognition and harmonized management. At this hospital, I have personally encountered one new patient every 3 weeks. Population studies based upon the new ICD-10 diagnostic code probably underestimate the incidence at 3 per million or 0.02 cases per 100,000 US inpatients. In the emergency department, as you learned from Dr. Edlow, thunderclap headache is extremely common, and I'll explain to you why that's relevant, because primary isolated thunderclap headache overlaps heavily with RCBS. The epidemiology also has confirmed the preponderance of women. In men, the RCBS syndrome appears to affect younger men and more commonly associated with sexual activity. Many triggers have been ascribed to have caused RCBS or precipitated RCBS. This is largely based upon temporal associations or physicians' biases in attributing the onset to certain exposures or medical conditions. As you can see, physiological exposures are quite common, about 30%, and this includes anxiety, stress, severe grief, which may be relevant to our case. The exact pathophysiology is uncertain. It is believed or proposed that the raphe nuclei in the brainstem have projections to the perivascular nerves, specifically the serotonergic and perhaps the trigeminal vascular pathways, which eventually release excessive serotonin or norepinephrine in the perivascular nerves, the abluminal surfaces. Their segmental distribution may explain the segmental nature of vasoconstriction, and heightened serotonin tone may explain the hyperreflexia and depression and sometimes long-term headaches seen after RCBS. Moreover, serotonergic receptor activity may also explain why some patients have depressed or distal edema. Endothelial dysfunction has been documented in some cases, including one that was a CPC in 2009 in a postpartum woman. Some have proposed a genetic serotonin polymorphism problem, and an immune basis, of course, still cannot be excluded. Based upon several studies, most notably these two studies, one by Dr. Chen and colleagues, they have shown that patients with primary thunderclap headache and those with thunderclap headache with angiographic changes have very, very similar clinical features and evolution. And they have proposed, and I agree with this, that primary thunderclap headache is part of the spectrum of RCBS. Walter Bartinsky and colleagues have shown that about 50% of patients with breast will have angiographic abnormalities, suggesting a tight connection between breast and RCBS. Therefore, we think there's an interrelationship between these three conditions. In this patient, the RCBS-2 score was 10. That's based upon all the variables listed over here. So I think there's little doubt about the accuracy of the diagnosis, because in the series that we published, this score had about 95 to 100% sensitivity and specificity based upon the variables identified. In this patient, the echo findings were relevant. There was some debate about the veracity of the echo results, but the presence of the same finding in the second echo, and then the case reports and case series, including this one, which showed that 17% of patients with RCBS do have transient anterior segmental wall motion abnormalities, suggesting Takotsubo. It seems that this patient probably had Takotsubo cardiomyopathy. Interestingly, there's an ever-expanding spectrum of RCBS aside from Takotsubo breast RCBS. We've seen patients with coronary and renal dissections, cervical artery dissection, and most recently transient global amnesia, where patients with severe headaches have been documented to have PCA vasoconstriction and tiny infarcts in the hippocampus, as shown on this slide. While preparing for today's lecture, I came across this New York Post paper, publication about a woman who, 56-year-old, developed an intense headache, went to the hospital, woke up with amnesia. Now, she remained an unknown diagnosis in the newspaper report, but I think it'd be quite likely that she had RCVS in the background. It's important to distinguish this benign vasoconstrictive phenomenon of RCVS from inflammatory conditions such as primary angiitis of the central nervous system. In the few cases with pathology, as shown over here, there has been no evidence of inflammation in patients with RCVS. There is excessive pleating of the internal elastic lamina, which suggests that this is indeed a vasoconstrictive phenomenon. What's shown here is a middle cerebral artery with special stains. It's fairly easy, if you know the details of the various features that overlap between RCVS and PACNS. Both conditions have headache, there can be infarcts, bleeds, perhaps edema, and angiographic changes, but the devil is in the details. In RCVS, it's a thunderclap headache, whereas in PACNS, it's usually chronic. The infarct locations and distributions are different, and the frequencies of hemorrhagic complications is different. Even on angiogram, as Dr. Romero showed you, there's this smooth segmental source appearance, whereas with primary angiitis, it's much more irregular and large. Oh, let me go back. I must confess that there are cases where the diagnosis remains uncertain, and here, advanced vessel wall imaging, CSF, biomarkers, retinal brain biopsy could be considered. But by and large, this remains a clinical imaging diagnosis. These are the lesion patterns of RCVS. Most commonly is a normal pattern, but on close inspection, you might find hyperintense T2 changes within the deep sulci, which is really a dilated cortical surface artery, which is end-on with slow blood flow within. Infarcts are typically symmetric, as shown over here. Vasogenic edema develops at 28%. Hemorrhagic lesions are common, including convexity, non-aneurysmal subarachnoid hemorrhages, or sometimes lobar hemorrhages. And then lesion combinations are very common. Now consider infarcts with press. They're small, as expected, with the nature of the inflammation affecting small arteries. They're more deep than superficial. You can also have white matter changes, leptomeningeal enhancement. We've described mass lesions, which on biopsy, biopsy being pursued for suspicion of GBM, for example, proved eventually to be a primary angiitis. And again, lesion combinations. Now, the distinction is critical because management of one condition may actually worsen the other. For primary angiitis, immune suppression with glucocorticoids is the mainstay of treatment. In our retrospective analysis, done twice, we showed that in patients with RCVS, glucocorticoids exposure was followed by clinical worsening and led to worse outcomes in patients with RCVS. So these are the cumulative event curves showing many more events, and the circles show you the discharge modified Rankin scale score, which, as you can see, is much worse in corticoid exposed patients. The triangles with the dotted lines indicate the timing of initiation of the glucocorticoid, suggesting that the worsening occurred after glucocorticoid exposure, suggesting that either it contributed or the treatment did not prevent worsening. Coming back to the clinical course of this case, she was discharged after the first couple of days in a stable condition on oral nimodipine. Unfortunately, she was readmitted via paramedics 2 days later due to worsening of headache, described as an 8/10 pain that improved by the time of hospital arrival. So severe but short-lived. She was apparently still clutching her head in the ambulance, and upon arrival, her blood pressure was normal. The neurological examination this time showed new clinical deficits, namely loss of sensation in the left face, distal right arm and leg. Additional imaging studies were obtained at this point. Okay.
Thank you. Here we're going to look at some radiological follow-up studies. In this image on your left-hand side, you'll see the FLAIR images demonstrating this hyperintense lesion within the bilateral cingulate gyrus. On your right hand, these are the fusion-weighted images demonstrating this acute infarction of the territory, and as correlates with the watershed actually territory of the ACA and PCA coming down from the cingulate gyrus. This is a sequence called SWI, susceptibility weighted images, very acutely demonstrates the distribution of hemorrhage, subarachnoid hemorrhage that we follow in the convexity, which could be later redistributed through the interhemispheric fissure. And we also see how there is already some hemorrhage within the infarction and within the subarachnoid space. And here's one of the really excellent images regarding digital subtraction angio. And as you can appreciate, there's this exactly the segmental narrowing and dilatation. And always, as I remember, Dr. Davis teaching us how to look at vasospasm, and so always you have to see a thick, a thin, and later a thick segment of vessel for you to mention what is a spasm and what is arthritis per se. So you can see that this vessel is involved in its branches. However, we also looked at other areas, and this is where this is critical for us in the diagnosis. As you looked at the images, you were able to see that the basal systems were clear of subarachnoid hemorrhage, and they were really focused on that vertex and parietal areas. However, you can see this again, as Dr. Singhal mentioned, this very nice pattern of dilation and segmental narrowing also on the superior cerebellar artery, and to a lesser degree of the posterior cerebral artery. So now we have two different territories involved, posterior and anterior, and not exactly related to the location of the aneurysmal or subarachnoid hemorrhage, which really guides us as radiologists. When you have vasospasm in areas where there's not a lot of hemorrhage, you have to think about other etiologies besides aneurysmal vasospasm from hemorrhage or an aneurysm. Here, I just wanted to show you the multiple territories that the patient had compromised. As you can see on your left hand is the patient that we are discussing. We see the middle cerebral artery, and we see this very abrupt thinning of the middle cerebral artery. On your right side, you'll see that this is how it should look in a normal patient. Not only that, you can also see the attenuation of the density of the contrast, and this is reflecting the lack of this decrease of flow to this area. As you can see in a normal patient, the density is equal in the proximal segments and in the distal segments. Here's just showing you the contralateral left MCA also had in this particular patient narrowing and thinning and segmental areas of spasm.
Thank you, Dr. Romero. I'll now describe the additional management. In general, our CVS treatment follows the principle of less is more. Patients have extreme pain, and symptomatic pain management is critical. Other than that, intravenous fluids, laxatives to avoid the Valsalva maneuver, which can trigger further thunderclap headaches, bed rest is important. Many physicians feel that a vasoconstrictive drug, if identified, should be withheld. It is recommended to avoid blood pressure management, except for very extreme blood pressures, to allow for autoregulation. patient. Calcium channel blockers are often administered, including amlodipine as in this patient and magnesium. However, there is lack of scientific evidence to support their use in RCDS. As I mentioned, glucocorticoids could potentially be harmful, so best avoided. And in select patients with either clinical worsening or imaging showing accumulating strokes, it is reasonable to proceed with angioplasty or intra-arterial vasodilators, such as nicotine, albeit there is a significant risk of reperfusion injury and there's the anxiety and fear of invasive procedures. In this patient, the pain was appropriately managed. She was treated with nimodipine, magnesium. She was sent in for the invasive intra-arterial parameter injection procedure in order to treat vasospasm in light of the new clinical deficits and the new infarct seen on the spleen of the corpus callosum. A follow-up MRI after this procedure showed evolution with a little more systemic hemorrhages in the corpus callosum, possibly suggesting mild systemic reperfusion injury. Nevertheless, she remained clinically stable and had an MRS score of 2 at the time of discharge to rehabilitation, 8 days after the second admission. The rehab stay lasted 2 weeks. It was also uneventful. She was discharged with mild attentional deficits, memory deficits, problem-solving deficits, which seemed to be improving throughout the hospital course. And she was left with persistent arm numbness. Follow-up. Over the past several years, she has not presented back with additional thunderclap headaches, and she has not developed strokes. This is typical of patients with RCDS. A repeat CTA and an MRI to evaluate for the persistent numbness. 2 or 3 studies performed within the 6-month span showed resolution of the arterial intracranial stenosis and subarachnoid hemorrhage, and no new parenchymal lesions. Cardiac stress test conducted 6 months after presentation was normal, supporting the notion that this was a transient reversible phenomenon without any significant coronary artery stenosis. Thank you.
So much. I just wanted to thank all of our discussants today, Dr. Edlow for coming and walking us through how you would approach that patient, Dr. Romero for going through the imaging, and Dr. Singhal for teaching us about RCDS. We do have some questions. I think Dr. Edlow wants to start off with a question.
Thank you. I have 2 questions. The first one is, the patient that we sent to the acceptable actions on the state of your condo association. And the second question is,
Aneesh, will you come back up to answer those? The first question, just for those ones, the first question is whether or not they're feeling particularly anxious when she spoke at the condo association, and then what was the rationale for them?
Thank you, Dr. Edlow. Very good questions. According to the chart review, we don't recall specific mention being made of anxiety. But I think one can assume that there is some level of anxiety when people get up to speak, not you and me, but maybe the patient has some anxiety. If you look at the case series of RCDS, there are many instances of patients getting up to speak or being put into positions that they're not accustomed to when they develop this onset headache. The lumbar puncture was, I believe, done to rule out cerebral vasculitis.
Thank you. Any other questions from the audience? Yes.
So I'm just wondering about the mechanism of the initial subarachnoid.
So the question was, what is the mechanism of the initial subarachnoid?
So the pathology can suggest that the vessel integrity is KRS. Do you think this is a structural failure vessels in context of reactive hypertension? Or do you think it's actually small areas of ischemia function in the vision presentation is something anchored to that?
Would you like to make this?
How about everyone comes back up and then questions can be handed off? Come on back up. Come on.
I can take this one.
I can,
Thanks, Todd. So I think the CTA does not show any structural abnormality. And as you heard from Dr. Edlow, the angiographic changes start distally and then proceed more proximally. We don't really know what causes the distal subarachnoid hemorrhage. I don't think it's hypertension because the effects of hypertension would be unlikely to cause vessel rupture that distal on the arterial tree. My sense is that this is probably distal segmental narrowing and dilatation, with perhaps small vessel rupture, which is transient, culminating in subarachnoid hemorrhages. There's no way of proving or disproving this. This remains simply a hypothesis. Turn to Dr. Romero, who may have other thoughts.
yeah, I think I agree with, I think it probably is a local structural injury to the vessel. One of the important aspects that you mentioned is, could it be an infarct that later goes in hemorrhagic? Actually, a lot of these cases don't have infarcts and have subarachnoid hemorrhage isolated. So I think there's not a correlation. In this particular case, there was some hemorrhage, as you will notice, within that area watershed, but a lot of cases don't have infarcts with our CVS, but do have. So it probably is a structural injury.
Yeah, the only thing I would add is, the veins are not unknowns. The known unknown here is what her blood pressure was when she stood up to give that talk. We don't know it wasn't too for a few minutes, maybe it came down by the time she got to the emergency part. So that might play.
There was another question in the front row.
Sorry, sort of the last question, I guess. How can you tell the differentiating who they are between RCPS and subarachnoid hemorrhage and primary subarachnoid hemorrhage with vessel constriction?
Mine is really
So let me see if I understand. How do you differentiate that this vasospasm is not secondary to the subarachnoid hemorrhage? So I don't think there's a very good specificity in what we have. However, one of the classical aspects of vasospasm secondary to subarachnoid hemorrhage is that there's a very nice correlation between the amount of hemorrhage within the area and the vessel that is compromised with vasospasm. In this particular case, as you can see, actually, their basocistern vessels are involved, the cilium fissures are involved. So we see a more generalized, actually a very accentuated vasospasm, even compared to patients who have high degrees of subarachnoid hemorrhage. So there's this discordance of vasospasm and amount of hemorrhage in these particular cases. So I hope that answers the question in a way that we see that differentiation in these cases, that the vasospasm is a lot more than what the correlation that you have with subarachnoid hemorrhage, with the amount of subarachnoid hemorrhage.
I don't think that's true. The evolution for the later sequence giants, margin, so system actually is late 2000.
That's a good question. There could be additive factors here. True. I think that is, it definitely, this case in particular, that ACA was the most affected vessel in terms of degree of narrowing and stenosis, but other areas were also affected without strokes. But you're right, there could be some additive factors in that particular case. I don't know. Yeah.
just one other thing we're talking, I never really understood it about it initially. My understanding at least is that the vasospasm and aneurysm subarachnoid follows many days after the initial hemorrhage, whereas this occurred hours later. So I would think that would be a strong argument against it being aneurysm as well as what the other people said.
Yes, Kevin, I think with aneurysmal bleeds, it's basically basal, the sylvian fissure and the basal cisterns where the blood is. This is convexity, and the amount of segmental diffuse vasoconstriction affecting the MCAs, ACAs, PCAs, SCAs is not typically seen with an aneurysmal bleed. Dr. Michael, oh, I'm sorry. Barbara?
Thank you for this very thoughtful discussion. And regarding and specifically the choice of house offer. So we use one a lot in and is there any literature showing that
Now, as clinicians, we give nimodipine to patients with this phenomenon based upon the aneurysmal subarachnoid hemorrhage literature. But as you know, even in aneurysmal bleeds, calcium channel blockers such as nimodipine are neuroprotective, but don't really affect the time course of the resolution of aneurysmal vasospasm. Nevertheless, it's given here for the based upon the vasospasm literature. There's been one retrospective review that showed that nimodipine takes the edge off headaches, but does not affect the time course of vasoconstriction in RCPS. There is no data distinguishing nimodipine from verapamil or any other calcium channel blocker. I too often give verapamil rather than nimodipine because of cost and convenience. Michael, left.
Okay, we're at time. If there are any additional questions, people are welcome to come down to the front. I just want to again thank Dr. Edlow, Dr. Romero, Dr. Singhal for putting together such a beautiful discussion. Hopefully we can raise awareness of this. And since we know what we're looking for, can find it and help patients. Thanks very much for all of your help. Look for this in the coming months in the